Welcome to Cold Steel, the Canadian Journal of Surgery podcast, with your hosts Amir Farouk and Chad Ball. The goal of the CJS podcast is threefold. The first is to highlight the best research currently being completed by Canadian surgeons. The second is to offer educational topics for both surgeons and trainees alike. And most importantly, the third goal is to inspire discussion, thoughts, creativity, and career development in all Canadian surgeons. We hope you enjoy it.
Hello everyone. From everyone at the Canadian Journal of Surgery, I just wanted to extend our best wishes and hope that all of our listeners are doing well during these unprecedented times with COVID. In the interim, we're going to keep on putting out podcasts for you to listen to. In this episode, we interviewed Dr. Neil Parry. Dr. Parry is a trauma surgeon at the University of Western Ontario, and we had a wide-ranging discussion with him, ranging from REBOA to pelvic packing, to really some high-level concepts such as how to run a trauma. We hope you enjoy. Dr. Parry, thank you very much for joining us on the podcast and taking time out of your very busy schedule. You're flying all over the country, it seems, and going to all different meetings and giving talks all over the place. So we really do appreciate it. Yeah, thank you very much. I think we just wanted to start off a little bit by asking you a bit about your training, where you did medical school, and how you ended up coming to Western.
Sure. So I did medical school at Western. I got in on the second round. I wasn't a first pick, but managed to get in. And then did residency here. I must say, when I was thinking about residency, it kind of came down to probably, at the time, my top ones, I was thinking either Edmonton or London, and it was mainly from Dr. Duff, who was our chair at the time, and Dr. Girardi, who were both here, big influences. Reason why I wanted to stay in London. Did the general surgery here, then went down to Atlanta to do trauma critical care with at Grady Memorial through Emory University with a great group there led by Drs. Feliciano and Rosicki. And then back on staff in London for a long time now, it seems, since 2003.
How did you pick surgery specifically, Neil? Like, why not gastroenterology, for example?
Yeah, that's a good question. Like, it's funny, in clerkship back in, when we did med school, you never got exposed to any surgeons. You didn't do anything clinical really until your third year when you started your clerkship. So I actually went into clerkship thinking, I kind of like the physiology of the kidney, and I'm just a little kid inside, so I like pediatrics. And I thought that's something I was going to do. So I started my clerkship with surgery, and lo and behold, it opened my eyes, and I just sort of fell in love with it. It was really the team aspect and the immediacy of it all that really drew me in. And, I kind of mulled around between plastics, ortho, and general. And then as a nice influential clerk that I was, or the senior resident I had on my medicine rotation, said, listen, if you want to look after sick people, and you want to do surgery, you got to do general surgery. And that's kind of how it all happened. It wasn't a big eureka moment in any way.
That's interesting. It's true for so many of us, eh? Everyone thinks you come in knowing exactly what you're going to do, but rarely is that the case.
Not even close.
Having known you for a long time, Neil, from the outside, and I think we've talked about this a little bit, it seems like you're having a ball in life, and that you're really you balance so much stuff so well. We've also talked about what balance means and how it's different for different people. But you have a great family. I hope you don't mind mentioning, but you have 3 fantastic kids, a fantastic wife.
Thanks. You
clearly have an academic footprint. You're on lots of national, international committees. You come to lots of meetings. We see each other all over the place. How do you kind of maintain that balance, and more importantly, how does that interact with kind of how happy you seem as an individual?
Yeah, it's a challenge, that's for sure. As we said before, a lot of some smoke and mirrors to make things work. I'm not one really to dwell on little small things, and I think, not to sound too, I don't know really about it, but with regards, there's no point really dwelling on a lot of negativity. So I try to be positive about most things, because I just think there's, putting your energy there is going to be so much more fruitful than being negative about things. And, as you said, my family has been, remarkably supportive, as have all my colleagues here in London, to allow me to do these things. I really do enjoy, most of these things. I like my committee work, outside the hospital more than, maybe I shouldn't say that. I take that out now. But I enjoy all the committee work, the camaraderie, and I really enjoy, always learning from other people and how their systems or just individual things are being done. And getting the balance again, it comes back to the support that's around you, and just trying to keep things positive.
Yeah, that's such a good piece of information. I mean, you guys in the trauma and critical care and acute care surgery group in London have such an amazing group. You've recruited so well. The group dynamic, at least from the outside, seems absolutely amazing. And we probably don't thank our partners enough, quite honestly, to allow us to do a lot of this stuff. And it's amazing to see a group like yours and how you guys leverage off of each other and support each other, and the general morale being so good. It's fantastic.
I just want to echo that again. You're absolutely right, Chad. Like the group that we have, it's worked out very well. Again, holistically and even selfishly, it's made my life so much easier. There's just fantastic people to be around and work with, and it makes, again, it just makes it positive. It's just that a good vibe, a good energy, to be able to allow people to pursue what they want to pursue.
Yeah, there's no doubt. I mean, just to go off on a tangent, maybe recruiting people's hard. Recruiting great people is harder. How did you guys manage to attract and recruit such great folks that fit so well?
Yeah, it's a good question. I think we've been, fortunate that it's been a bit of a, London always sort of had this reputation as being a hard-ass general surgery place. People get beaten and worked into the ground and that sort of stuff, and that's clearly not true. Yes, we work hard, and so does everybody everywhere. But there's a really good sense, and I think that's come historically from Dr. Duff, Girardi, Ken Leslie, these leaders that have just demand respect and responsibility, and it comes down to treat everybody equally, and it just comes down that way. So with that comes down to the residents. The residents are fairly happy. I think, again, that's just my outside look, but we've been able to engage a few residents that really liked the acute care sort of surgery side of things and the trauma. Have gone out way to do fellowships at great places and have come back and have added just tremendously to the program. So we've been fortunate to be able to recruit them back and not get stolen away somewhere else.
Yeah, it's amazing. Such a great group. You and I often see each other at lots of different events nationally, internationally, and I was wondering what your take on especially for trainees, whether it's medical students or more commonly residents and occasionally fellows and junior staff, what your thoughts are on how you target a particular society to join. So what's important? What do you get out of it? And then similarly, really the same question for associated conferences, maybe either general surgical or subspecialty wise. What do you think of all that if you were to give those folks advice?
Yeah, I think that early on in our training, and then as we move along through our careers, they change. And so early on, I think it's to be able to meet other people and connect, to try to get some feelers out and to get a lay of the landscape, and really just to learn how these systems work. So the premises of all of these, it has to be something that you're really interested in. There's no point in trying to join a conference because, wow, someone told me this is a great one, I should join, but you don't, that subject doesn't interest you. So there has to be that passion there behind it at first. So I think early in the career, that's the main reason why. And then it really, as your career develops and you find a clinical or an academic interest, which doesn't have to be just in surgery, could go around from there, And then that would really sort of drive where you go. And of course, your own mentors provide great advice as to where to go, and certainly open doors for us all. That's for sure. I've been very fortunate that way. And I think it's almost the same as along with conferences. I think with the societies, that's one, and most societies have their own conferences, and then depending on what your academic bend is or the clinical bend that one has, that you either want to join some committees that you think may be able to actually make a difference, and because they certainly do, they have a lot of these societies. And then also, if that's where the academic side is, that you want to, present some of your research or to partner up and link up with other people, other groups.
Yeah, it's so true. I mean, it's interesting to have watched a lot of the societies change over the past, I'd say, less than 10 years. There's really becoming a culture of volunteerism and solicitation, as opposed to having to wait until you're, say, mid-career to even walk onto a committee. And that's really become the culture in a lot of different societies, and it's interesting. Yeah. I think for the good, but it is interesting.
Yeah, I think that most societies now are acknowledging that you don't have to be, mid-end career to be able to get onto this committee or that they seek out, younger staff and rightly so, bright and energetic. That's the first thing, of course, but also because the culture's changed a lot, and it has to, and it has. It has to be more dynamic and diverse.
Well, I think you see societies, as you point out, change over time too. I mean, the reality is there's 1,001 societies. It's too many, and there's always someone saying, "Come to this and join that." But people speak with their feet, and certainly societies become increasingly or decreasingly popular over time for that reason, no doubt. That's really great advice.
I wanted to ask you, Dr. Parry, because we actually, speaking of conferences, we actually interviewed Kelly Vogt at the last CAGS meeting. She talked a lot about, returning back to this idea that you guys have such a great group at Western. She talked a lot about how powerful it was as a young staff to come back and have really good mentors. And, we often ask, young surgeons, and they always talk about having good mentors, but I kind of wanted to pick your brain. Like, what do you think it takes to be a good mentor for young and upcoming surgeons? And what are you guys doing that has made that so fruitful?
That's a good question. We do have mentorship committees now. In the last probably 5-7 years or so, we've established those. But I think that's more of a something to double check and make sure that people are on the right track. It's not it's a formality. I think the real mentorship that occurs is much more on the informal level. And whether you go on to formalize that or not, I just think that's maybe just moving the deck chairs. But I think that's where it really starts. And you learn from your own mentors, right? Just so much of that is environmental, and if there's a good environment for that, and that's that you're very thankful of how you've been trained and how things have gone, then you tend to pay that forward. I really do believe that, and so. With Kelly, she might have been excited to come back, but we were ecstatic, the fact that she was coming back to work with us. So it's pretty easy, to be a mentor and to help somebody along in their career in that path. I don't think there's anything really super specific about it, though.
Yeah, it's certainly not an easy question that I've asked you, and I don't think there's any secret sauce, but kudos to you guys for being trying to make that Western such a great place to come and work.
Well, thanks.
If it's okay with you, then I'd like to switch gears a little bit and hit you with some clinical questions, because a few of us have a little quiz coming up at the end of the year.
I know nothing about that.
Yeah, exactly. So here's a question, and I kind of have a few different layers to it that I'd like to pick your brain about. So the scenario is that there's a 40-year-old female brought in by EMS after suffering a head-on collision. She's unstable in the trauma bay, tachycardic and hypotensive. On primary survey, it's clear that she has a significant blunt pelvic injury. A binder is applied and she is resuscitated. And I think the first question I want to ask you about this actually isn't specifically clinical, but I've seen what the trauma bays are like in Calgary, and unfortunately they're often quite chaotic. And no matter how much our trauma staff really have tried to have meetings and sit down, it really seems quite challenging sometimes to maintain a certain sense of order while still keeping some urgency. How do you think, what sort of tips and tricks do you have for maintaining some control over a tough situation like that?
Yeah, I mean, that happens with us for sure. I think it happens everywhere. There's lots that has been written and attempted in order to sort of decrease the mayhem with, stickers, different colored gowns that people wear, different colored hats, whatever, perimeter tape where you can't come around. I think you have to have to step back. You need to have somebody who's a good leader. So the person who's the trauma team leader needs to be able to take control of the situation. That doesn't have to be the general surgeon or the trauma surgeon. If someone's sick like this, I think should be the one who takes control. So that's the first thing, is you need somebody who can do that. And with that, then, as I tell our residents and fellows and that sort of thing, you be respectful, but we're not there to make buddies with everybody down in the trauma bay. You're there to save that patient's life. So, respectfully say, okay, who's not involved? No, you, okay, stand back or get out of the room, please. And then, everybody should have an assigned task. We've recently just gone to the stickers so people will know who people are. So who's the trauma team leader, who's from general surgery, anesthesia, ortho, emerge, that kind of stuff. And I think that helps just with communication within that area when it's sometimes chaotic. But it has to be a good leader to be able to take control of the situation.
That's awesome. Is there I've seen, so obviously I've worked with Dr. Ball and the trauma surgeons here, and everyone's a little bit different. What do you where do you stand? How do you talk? What are you, someone who wants everyone to verbalize things? Tell me a little bit about how you actually run a trauma.
Sure. So I'd be right at the end of the bed. Usually the foot of the bed is where our trauma bays are set up. So if you're there before the patient gets there, have a little bit of fill in the team as to what we know about the patients and what potential things we may need to do and what things we may need to do very expediently. And then once the patient arrives, usually we get them over onto the stretcher or onto the trauma bay, and then get a bit of a handover from our EMS or whoever's there. And then I would ask, someone else, depending on the severity of things, I'd ask someone else to act as the TTL, and I would sort of stand back and sort of just watch how that person does. If they're doing a great job, perfect. If they need a little help here and there, I'll chirp in from the cheap seats. I don't have a problem doing that. And then I do like it when the person who is doing the primary and secondary surveys and that does speak. I don't like a lot of people talking in the trauma bay. There always are more than what you like, but so, you have to bring the volume down and just wait to hear what's going on. That's generally the way I would run it. I don't tend to get my hands involved unless somebody else is acting as the trauma team leader and they need me to do that, or if somebody's struggling with something. But generally, you'd be sort of at the end of the bed.
Gotcha. Okay, so the next question I had related to this scenario is sort of the whole question about resuscitation, because I think that has really evolved in the last little while. People are talking about whole blood, different ratios, and so what are your thoughts? What's your choice of resuscitation fluid? And sort of along those lines, do you think Canada is ever going to get to the point logistically where we can give people whole blood?
So, yeah, I agree. Things have changed a lot from the days when, I was a resident and resuscitated with crystalloid, liters and liters. Trauma patients are bleeding, and bleeding patients need blood. And they need to give it back in the way that they lost it. So, we do need to have a balanced transfusion. Most centers have some type of massive transfusion protocol. Even some smaller centers do, and regionally they have ability for that. In Ontario, any small community hospital or even a very, very small hospital has at least 2 units on scene or at their hospital, so we can use that. We can activate our massive transfusion protocol before the patient arrives, so we can have blood and FFP in the room prior to arrival. So I think that, you want to minimize, I totally believe that we should, as we just need to resuscitate with blood. The exact order of the products, again, is being looked at quite a lot recently, and whether we should start with our plasma. There's some evidence to suggest that may be beneficial. But I think that's really getting into the weeds right now for this question. But, a balanced transfusion would be the way to go and get that blood, ready for when the patient hits the door. With regards to whole blood, yeah, I don't know. I mean, that's just never mind just from the medical point of view, and I'm not sure if that's exactly what needs to be done. But just the logistic, political, and economic climate, with Canadian Blood Services, I don't know really how that would all play out.
Okay. That's a great overview, I think, of how resuscitation has really changed. So let's go back to the patient that we have in the trauma bay, and let's say she arrests in the trauma bay. And I kind of wanted to get a little bit into REBOA. Are you guys using REBOA at Western? And if so, what sort of scenarios are you using REBOA in?
Yeah, so we've used it, I'd say now 3 times. And we have exclusively just for the hemodynamically unstable pelvic fractures and are deployed in Zone 3. We don't have the 7 French one. We still have the old Coda catheter. We don't have the Prytime one here. So it's a bit of an ordeal. We set this up with our vascular surgeons. And we keep the kits actually up at the OR desk, so someone has to bring them down to the trauma bay to get them done. Once if we decide that we're going to use REBOA automatically, that books the operating room as what we would have as an A case for an emergent case. Vascular surgery, the fellow is paged at the same time, and then he or she comes in and we'll do the REBOA catheter along with the general surgeon who's on, or the trauma surgeon who's there, and then we transfer the patient right up to the OR with generally the REBOA has been placed in the emerge, and then get them right up to the OR. So we've only done it 3 times successfully on 2 out of the 3. One was an older guy who had really tortuous and atherosclerotic iliacs, and we just couldn't get the catheter in, so we abandoned it. But it was in the OR at this point. So we did not use it a lot.
Neil, let me ask you, REBOA, I guess we've talked about it for a long, long period of time in North America, and some centers are certainly leading the way and really certainly overusing it to try and figure out its true utility. There's no doubt. But I would argue probably in Canada we're a little bit behind in terms of using it, and certainly the second catheter that you mentioned with the 7 French introducer should help that. What are your thoughts on who actually deploys it and who manages it? It sounds like, as you said, the vascular guys are heavily involved at your site. At our site here in Calgary, the Foothills, we don't have vascular here at all. I've been personally deploying Coda balloons and a number of vascular balloons for 10 years probably. sometimes very well and indicated, and maybe sometimes not, but certainly they've been helpful. So what do you think about it in the pre-hospital context? You look at London, England, for example, and what they're doing at HMS to us. How do you put all that together?
I don't know. I think, that this pendulum has swung still really far for REBOA is super cool and we should all do it. I think it's going to swing back. I'll preface that in a sec. There's a really interesting paper that a friend of mine had forwarded to me. It just came out of the Royal Albert in Melbourne. And looking at, they have a very, very mature ECMO program there. And so they wanted to look at the feasibility of doing REBOA. And they have an incredible inclusive trauma system in the state, and really basically just go to one of two hospitals, as you know. And they at the Royal Albert, they would see about over 3,000 trauma patients a year, generally ISS greater than 12, that sort of thing. They thought maybe REBOA would be used, and they're looking at the data prior to the study, and say 7 to 10 patients, it may have been helpful. So they wanted to implement a team to have 24/7 deployment of the REBOA. They used the CODA. And they said, okay, we'll do it in patients whose blood pressure is 70 or less when they present. And in that, they had, I think, 13 patients or so that came, and none of them had any REBOA deployed successfully. And so their conclusion with all this is, one, even with try to get a mature team to deploy REBOA, they couldn't really get that working as well. And then two, the patient population just weren't sure if really that would have helped with any of them. So I thought it was a really interesting way to look at it. And so I think it's going to swing a little bit around as far as how it all goes. But for us, and I think for every other center, it has to be local. It has to be local culture, and from interactions with our different specialties, whether you need to have vascular or not. With us, we have a great relationship with our vascular surgeons. They're at the same hospital, of course, which makes it much easier. So we just opened the door and said, this is what we would like to try to do. There's a little hesitancy initially, and then we came up with a protocol and went forward with it, and there hasn't been any issues with it. Although, again, we haven't found the right, exactly who the right patient would be that requires REBOA, I don't think either.
It kind of goes along with many new things in surgery where there's a lot of initial excitement, and then it's always much more challenging and in real life when the rubber hits the road to actually figure out where does this get best deployed, and there's all the practicalities of getting the right team and everything.
And it depends on your access to the OR. If you can get to the OR right away, do you really need the REBOA? If it's delayed a little bit, will that be helpful? So there's all these little nuances which are really, really difficult to tease out. I think there is a role for it. I just don't know what it is yet. And my bias would be just the patient that you've mentioned with these hemodynamically unstable pelvic fractures. We in our protocol here in London, we would not put it in somebody who's arresting. Now I know that that's being done a lot, but we didn't feel that we wanted to start with there.
Gotcha. The last question I wanted to ask you about related to this particular patient and scenario is a lot of people, and particularly some centers in the U.S., talk a lot about pelvic packing. Is that something that you find helpful, and where do you think that should sort of fit in our algorithm?
Yeah, I do believe it for sure. I think, again, you can look at, online, and you'd be able to find, probably half a dozen, very reputable and evidence-based as best they can, algorithms for management of hemodynamically unstable pelvic fractures. So, when there's that many, there's probably not a right way to do it or not. But my bias would be, certainly if someone comes in who's got an unstable pelvic fracture, regardless of everything else, it's easier if they've got a positive FAST and whatever else. But if they just have the pelvic fracture, I think they should be resuscitated in the operating room. So we get them up to the OR. Again, depending on how your relationship is with your orthopedics, your interventionalist. If you have a hybrid suite that you can use or not, that'd be the ideal place for it. Again, our vascular surgeons have that here, and we do use their OR if it's available. If they're not currently in it, we can use that for these unstable pelvic fractures. The way we would do it is we'd have our orthopedic surgeons come up. As we go to scrub, depending on who it is, if they've got one of their staff guys that are here, they're fantastic, and they can get on an X-Fix in a couple of minutes. As they're doing that, then we would prep out the abdomen, and then I would do pre-peritoneal packing after that. I like them to do the X-Fix first, because if we pre-peritoneal pack, I don't want them to do the X-Fix afterwards, and then we sandwich in, and then get some sponges caught in between the bone fragments. And then see how the patient does. If they stabilize off from there, then okay. If not, then if we're fortunate to be in the hybrid room, then we shoot an angio. So that's kind of the way we do it. That'd be my sort of algorithm, or extrapolated from various others that we would tend to do here. Some of my other partners would do something differently, perhaps. They may go to angio more, but I really think the pelvic packing is very, very helpful.
Can you just describe briefly your technique for doing that for those who haven't done much?
Sure. So if there's not another indication for laparotomy, then you just do a lower midline incision. Start a few centimeters below the umbilicus and get down to the symphysis. Get down through the fascia without going into the peritoneum. And then once you're in that pre-peritoneal space, and space of Retzius, there'll be a huge clot that's in there. You'll be able to really just, the blood does all the dissection, and you can scoop out the clot, being careful not to cut your fingers, because that's pretty easy to do. And then I leave the packs, your laparotomy pads or packs, whichever you want to call them, leave them folded up, and you can usually get in 3 to 5 or so per side. And then I would, just stitch up the fascia, or you can put a vac over it, whatever. But if you can get the fascia closed, I think it provides a bit more tamponade. And then, bring them back when their physiology starts to correct a bit more, and then to remove them. I've not had to repack twice, interestingly enough, with these. You're successful within just the packing of them once, and you can get the packs out and then be able to close things definitively. If the patient's you need to do a laparotomy, then you can truncate your incision to just below the umbilicus and then leave a bit of a bridge to do a lower midline, or probably what's even easier is to do a Fannin steel type incision in that case, and then be able to do your pre-peritoneal packing through it.
So you do your laparotomy where you leave a bit of space so that you can actually still get into that pre-peritoneal plane.
Yeah.
Gotcha.
Yeah, because you need to have that, people will describe doing a full laparotomy and then entering the space of Retzius from within the abdomen, getting down, but you really don't have any, you can't really get a good vector packing that way, the same way you can from coming anteriorly above, if you know what I mean.
Yep.
So I would do 2 separate incisions if that's what I thought. And also, if someone's got a bad pelvic fracture, if you go straight down through there, then they're gonna bleed out like crazy. We've all done that before, where they bleed a lot from the lower part of their wound because it's coming up to the extraperitoneal plane. What do you guys do in Calgary then?
Yeah, it would be similar. Because the Raptor room is kind of always ready to go. It just depends on their instability. Usual thing, like if we're waiting for them to come up or come in, and they're really in trouble, same exact thing. We'll fix them and pack them and bide time. Sometimes they're there if it's in the middle of the day real quick, so you don't need to, but yeah, same thing.
Okay.
So switching gears once again to a very different scenario. So this time we now have a 25-year-old male with a seatbelt injury and a positive FAST that is unstable. And for some reason, every CAGS exam I've ever written has this scenario. So that's why I'm bringing it up. And I'm never sure what to do.
Full disclosure, I don't write the CAGS exam, but I do participate in writing your big exam in the spring, all right?
Okay. I know who to blame then. Okay, so this 25-year-old has a positive FAST. So you take him to the OR, and he has clearly has a duodenal injury. But there also seems to be an injury to the pancreas with pancreatic fluid leaking. And the patient is now stable. Has been resuscitated in the OR. So I thought I'd ask how and it's perfect because we have Dr. Ball on the line as well too. How do you guys approach a possible pancreatic ductal injury, and how do you delineate that, and then how do you try to manage it?
Yeah, so I guess the patient stability and with, as you know, with these pancreatic or duodenal injuries is often major vascular injuries involved as well. So that all depends. But in this scenario here, where patient stabilized, when you need to be able to identify if there's a duct, if you see, a clear transection, then some, pancreatic fluid mixed in with the blood, if you're ever so lucky, then that's obvious. I think that when it gets very difficult is when you're unsure, if your eyes and your fingers are better than any other tests you can do in the operating room. So if the gland has a big central area of maceration, or it looks like it's been transected more than 50%, or obviously transected right in half, then you go on and do your resection depending on where it is. If it's to the left of the mesenteric vessels, then you just go and do distal pancreatectomy and, most likely splenectomy at the same time. You can't do splenic preserving if they're super stable and nothing else is going on, but most of the times that's what we would do. With the duodenal injury, with this type of scenario, it would most likely be a blowout injury. Those, for the vast majority of those, you can just debride back the edges and repair those primarily. I don't think any of these fancy maneuvers of all the different, types of tube drainages, exclusion and all that type of thing is really necessary. Where it gets really, really tricky, obviously, is when it's, right in the head, or it's just to the right of the mesenteric vessels. And then that makes it much more challenging. Again, the principles there would be to stick with the life-saving maneuvers from the exsanguinating hemorrhage, control that. In my hands, that's what I would do, and then probably drain, and then call a friend like Chad Ball and say, "Hey, dude, someone who's got significant expertise in this area, where you may have to do a staged Whipple down the road." Again, if you start out like that, and then it'd be good to hear what Chad says, but it's a little different when you're also, where Whipples is part of your everyday life in your elective surgery practice. And Chad will say it for sure, but the group that's probably contributed to this the most in the literature is the South African group, and many of, and what, I think 3, Chad, are HPB surgeons as well, and they have the biggest sort of series on doing traumatic Whipples, and with excellent results. But that's because of who they are and what they do in their everyday trauma or everyday surgical lives.
Dr. Ball, do you have anything to add to that?
Not a lot. I think that's beautifully said, Neil, for sure. Neil and I see most clinical things exactly the same way, just based on our training. But I think the overriding take-home principles, whether you're doing an oral exam or a written exam, or you're maybe working in a community center, and one of these, you're unlucky enough when one of them comes in, are exactly what Neil highlighted. So number one, you have to stop the immediate threat to that patient's life, which is going to be bleeding. and that can be venous, it can be arterial, it can be a combination of both. So that's number one. Number two, I think, as an overriding principle is get help the best you can. Now, if you're in a small rural Alberta town, that might not be possible except over the phone. But certainly, if you have access to more experience or just educated hands, that's huge. And number three is, don't try and do too much. Don't try and do stuff that will change the trajectory of that patient. Sometimes less is more until, as the South Africans would call it, the pancreatic cavalry arrive. And I love the fact that Dr. Parry brought that up. The group in Cape Town it's exactly right. They've published really more on this in the last 15 years than anyone else. And on the HPB side, they're led by Professor Krieg, who's just recently retired, but as he was retiring, did a full PhD in pancreatic injuries, and that's where a lot of those recent papers have come from. And what you see when you go there and you're friends with those folks is that the interaction between the HPB surgeons and the trauma surgeons is almost like nothing I've seen anywhere else in the world. They are very, very close and very tight, and they deal with those injuries together. And there's no question that the pancreas surgeon is going to think about it differently than the trauma surgeon, and vice versa. Sometimes you need both of those voices to provide optimal care, because I think, in terms of the eventual plan, sometimes the trauma surgeon will undertreat that patient, and sometimes the pancreas surgeon may overtreat them. But that discussion is, if it's respectful and knowledgeable, is quite amazing to be a part of.
Well, on behalf of the other poor souls who have to write their final exams this year, I really appreciate that discussion, and it was a very good overview of some fairly frequently tested and real life scenarios that we might have to deal with.
I think we could also, I think Chad would agree with this as well, but you'll read some interesting things that are still in textbooks on how to identify ductal injuries, and they're just silly.
Yeah, well,
that's all I'm going to say.
Exactly. There's as Maddox would say, the printed page can tolerate anything, but patience can't.
Yeah, it's very true. The only thing to that I would add potentially is in some penetrating injuries, particularly stabs, the ultrasound is a beautiful tool. And although, granted, 99% of surgeons are not looking at pancreas or pancreatic ductal anatomy with an ultrasound, it's a pretty simple task as long as the gland isn't super beat up. If it is super beat up, don't even waste your time. But it's another skill that a trauma surgeon maybe just pop into an HPB surgeon's room once in a while and have them show that to you when they're doing a pancreas case. And it's a skill that can be very helpful in those weird and wonderful scenarios like you've described.
Fantastic. I have one last question for you, Dr. Parry, and that is, sure. As someone who's about to enter into the great blue yonder, if you had one piece of advice for trainees that you wish someone had given you at my stage, what would that advice have been?
I think one of my mentors when I went for my fellowship, he sort of said, "Hey Neil, come here. I got a piece of advice for you. It's eyes and ears open and mouth shut. You'll be just fine, kid." And it sounds kind of silly, but it's true. You got to keep your eyes and ears wide open for everything. Not necessarily the mouth shut part. To go into it, you're just finishing 5 years of very tough training. You are going to be arguably the most book smart that you ever will be for the rest of your life. Just before you write that exam, so I'm sure it filters out quickly. But you have to maintain. You have to maintain and be humble, and definitely try to find a senior partner where you're working that you can talk with openly, have establish that good relationship, and quite frankly, that's it could be a rate limiting step for where someone may decide to go or not. I think it's really, really important to have that. We talked about mentoring before, and as more senior surgeons go along, I think it's certainly in my mind, I think it's our duty to be able to mentor younger colleagues. And again, whether we do this formally or informally, it's debatable. But that's what I would look for if you're just going out into the so-called real world.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.